Behaviour counselling is a broad term where we kind of go, well, we know that intense near work coupled with not enough time outdoors may well be part of the trigger of early myopia development. So regardless of your journey, whether you're not yet short-sighted or already short-sighted, then maintaining some good visual habits of taking plenty of breaks with near work, getting up and moving around, preferably outdoors, spending as much time as you can outside, at least 90 minutes a day outdoors, and trying to keep your device use under 2 hours per day is kind of a general bit of advice, and certainly a strong one for people who are not yet at that myopia development stage. I think we can all confidently now say that just prescribing a distance lens is probably not really an appropriate thing to do anymore in someone who's highly likely to progress. And so, the younger you are, the more parental history they are that you have, and depending on your cultural background, these are all increase your risk factors for progression. So if you sit in that sort of medium to high risk of progression, then just prescribing glasses to restore distance vision and doing nothing else is probably no longer appropriate, particularly when we've got so much choice now of, especially in Australia, where a lot of the leading research in myopia for a long time has come from Australia. So I'm very fortunate in that regard, and our close proximity to Asia as well means that we have access to a lot of myopia control products, and a lot of them are optical devices. So we've got really started out, one of the leading ones that probably has one of the most bits of literature and research around it is orthokeratology, which is the lenses that you put on your eye overnight. And I've worn them as an adult to correct my myopia. It wasn't for controlling my myopia. It was just certainly just a method of restoring distance vision. And so it started out as an adult treatment to have something as an alternative to contact lenses, laser surgery, because you could wear a lens at night, take it out when you wake up. Because it's a stiff lens, it's temporarily reshaped the cornea on the front of the eye, and you get this benefit of seeing clearly. And the accidental discovery that came from that is, when you fit kids and teenagers with them, their progression in their myopia appeared to slow, and the research has certainly backed that up now, that that's a primary strategy for slowing progression. So you get to see clearly without wearing glasses, and also you slow the development of your myopia. You can also do that through a contact lens that you wear during the day. Now, it's not reshaping your eye, but it's creating a certain type of optical defocus that they have shown slows myopia progression. So you've got a number of different soft contact lenses. You can call them dual focus or multifocal. There's lots of different names. The main idea is that they're not a single vision sight correcting only lens. And so we've got those available, and they've been around not quite as long as Ortho-K, but certainly getting fairly close. And things like the MiSight lens, this natural view, this the seed lens from Japan, there's the Milo, I think, from Spain. So there's a number of different lenses available.
Sorry, they're all daily disposable, are they? So like the soft
Those are all
contacts that
daily
you just throw
disposable.
away. Yeah.
The Milo lens might be a monthly. We can use some monthly disposables where, if someone's got astigmatism, that is too much to be corrected by a normal daily myopia control lens. We've got those sorts of things that we can order. And then you've got spectacle lenses, and there's a number of spectacle lenses that come on the market over the last couple of years. I can think of at least 5 or 6 now available in my practice that we are able to choose from based on the individual needs of the patient. Actually, it might be closer to 8 now I think about it. So we've got plenty of choices, and they all have varying degrees of ability to slow progression on average.
Right. Yeah. Just on that point, I I do they all use like the same sort of defocusing approach to slowing myopia? And if so, like, what is the difference between the lenses? Like what would prompt you to say, okay, I think you should choose MiYOSMART versus Stellest or something else?
Yeah, look, some of it might be that you might choose it based on the population that lens was studied on. So if you're dealing with someone where a lot of the data from that particular lens came from Asian countries, and you have someone who has an Asian background, then East Asian background, then you might choose that lens versus someone who is Caucasian and use a lens where the data comes from sort of more Caucasian studies. That can sometimes come into it. There are some people with myopia who also have different forms of binocular visual dysfunction, and there may be varying degrees of weighing up the tension between making sure that you're paying attention to other aspects of how they're functioning visually and the myopia. And so you might be leaning into a lens that maybe might not be as effective at controlling the myopia, but provides quality of life in other ways. So there are some of the other things that you need to balance, and that's probably something that's sometimes overlooked. Is everyone gets caught up on the myopia aspect and forgets the person that's got two eyes and has to have good function of the two eyes working together in terms of binocular function and focusing. They're probably the primary things. You might adjust it based on the risk of progressing more rapidly because they're younger versus older. So there's a number of different things that you might use to consider for that individual patient that's sort of sitting there.
Okay. And are there therapies? Are there exercises that you can do to slow down the myopia?
Look, the research into doing vision therapy or exercises is just for myopia specifically is not there. It would be an interesting thing to look at because there appears to be influences in certain types of binocular dysfunction into myopia progression, higher versus lower. And it would be great to have those studies, but trying to get funding for that when the approach to myopia at the moment is a global approach at trying to reduce the overall levels. So they're looking at sort of what are the simpler strategies. So it tends to be sort of fairly lens based. If someone's got symptoms from binocular visual dysfunction, then certainly vision therapy has got a place there, but we don't go into it as something where you're promising any sort of control over myopia. I've certainly seen the odd case where we've been able to reduce the amount of myopia a little bit with the vision therapy, but it's not something that I would recommend as a primary strategy. Really getting into using lenses as our primary strategy at this stage.
And just in case anyone's thinking about this, so LASIK and like laser surgery for vision correction. I mean, I think that's something that they probably don't do on people whose eyes are still developing anyway.
Certainly in this country. So certainly in Australia, it's you have to be 20 and you have to be stable.
Yeah.
So, and if we take an example of my Ortho-K patient, so we opened the practice over 20 years ago with two things in mind. We wanted to provide Ortho-K and myopia control services to the Gold Coast, and we wanted to have a very professional, dedicated setup for doing vision therapy. And so I've got people who have been wearing Ortho-K for quite some time. And so we have that discussion as they are starting to get to an age where they might want to consider doing something other than lenses, glasses, or Ortho-K. And the discussion I have is, well, we need to at least wait until you're in your 20s because the surgeons prefer that. Part of that is traditionally your progression slows. I think the old data used to be about 1 in 10 people in their early 20s still progress, and about 1 in 20, so about 5%, still progress when they're in their mid-20s. I think with modern life, the data's potentially more like 1 in 3 still progress. So we need to be really sort of cautious around that. So my approach with an Ortho-K wearer is to say, okay, let's get through your studies, let's get through high school and uni, stop wearing your Ortho-K for 12 months. That does two things. You move into regular contact lens wear or regular spectacle wear. It allows plenty of time for your eye shape to return to its baseline. And because that's the part that they're going to laser is the cornea. So we want to make sure that shape has returned to its baseline shape. And we also want to demonstrate that you're not going to progress when you don't have something there trying to stop the progression, to prove that you are now well and truly stable. So that's where laser surgery sort of fits in this whole scheme of things. You want to be someone who's definitely stable.
So just to be clear, so laser surgery, it might fix the refractive problem, but it doesn't do anything to stop that eyeball elongating,
Correct.
does it?
Yeah, and I haven't seen strong enough evidence, and the practicality is that no one in this country is going to do LASIK on someone who's young anyway. So that's a big point either way. But yes,
Yeah.
it's only about restoring. It's just another way of restoring clarity in the distance again.
Yeah. And I've heard that like with all of these types of myopia control strategies, the earlier you start, the better the results. So like you're gonna maybe get more, um, you've got more hope of success if you start with a child who's maybe 7 or 8 than one who's 15, 16. Is that right?
So the it's more important to really be careful around getting in early. So this is part of the conversation you have with parents that, you know, a late starter can still progress. So we still need to manage the progression. So there's still value in managing the progression at any age. The concern about the early starters is that they've got a lot longer for the progression to be in place. So there's two things that happens when you're young, that when you do progress in your myopia, the changes over time are a lot more rapid, and the amount of time that you've got to develop myopia is longer. So you've got two things that kind of make it a big concern. And part of this is based on, you know, in an ideal world where we'd be able to stop myopia in its tracks. The reality is we just slow it down. And we're trying to avoid the average level of short-sightedness from hitting about -550 and higher. And so, you know, the younger you start, the quicker you go, the longer you have for, you know, eventually reaching those kind of levels.
But that slowdown could be, I mean, the cumulative effect of it, you know, it's not nothing, is it? Like, yeah, I think with some of the studies they talk about reducing that progression by 50 or 60%. Is that right?
Yeah, yeah. So your Ortho-K, your higher doses of atropine, your contact lens where you're sitting in that. So I always say it's around that 50 to 70% kind of level. And you know, the glasses on paper are saying similar sort of levels now. We've just had a little less time clinically to see if what we're getting in the clinic is matching kind of the data. And there are other types of lenses where the progression control is probably around that 30 to 40%. But they're all contributing in a way of actually slowing it down compared to just doing nothing or wearing a regular pair of glasses.
Right. And well, just to paint the full picture here,
Mm.
we should probably talk about atropine eye drops.
Yeah, so
That's been something that's been around for a while, hasn't it, as a strategy? But I think that some practitioners like yourself have sort of like a mixture of views about that.
yeah, yeah. So look, I'm not against it. We tend to use it in a situation where the other strategies aren't working well enough for a particular patient, or for some reason they're just not available. And the thing with atropine is that the higher doses certainly slow down the progression more, but you get a high dropout rate because the side effects from the drops start to make the treatment sort of something that someone doesn't tolerate. And so once you lower the dosage down to a more tolerable level, you are getting similar sort of outcomes from atropine that you get from spectacle lenses, contact lens wear, and Ortho-K. So you kind of go, well, we're going to have to correct your sight anyway. Why not use the optical devices first? Because you're going to have to correct your sight anyway. That way you don't have this additional drop that you need to kind of be doing at the sort of same time. And there's research going into how effective they are as an adjunct therapy. So if you've got someone in Ortho-K or myopia control contact lenses and their progression is still more than you would like, is there benefit in using a atropine as an additional one? But that the research is still equivocal on that one. And there will be some people who hear about atropine and that's the approach they want to take, and I will refer if that's the way that they go with it. Like I said, you know, the vast majority do well in our, let's call it, regular myopia control strategies.
So what I'm hearing you say is that if your child has an obvious like refractive problem, they're struggling to focus on things, then eye drops maybe are going to slow down myopia, but they're not going to help them see better.
That's right.
They probably need glasses or contact lenses anyway.
Exactly. They're still, you know, they're going to have to wear. And there is an argument that not wearing glasses or wearing a weaker prescription may actually increase the progression. People sort of talk about a lot. My looking at the research is I don't know how much impact an undercorrection or no correction actually has on myopia, other than it's not a strategy you choose to use. It's not effective. I don't think it's necessarily better or worse than full correction. I just don't think that full correction or no correction works at trying to slow down myopia at all. So, but the reality is, yes, if you're becoming myopic, there's just the quality of life issue of not being able to see. And so, you know, you need to see, you need to have glasses. And then if your option is atropine to slow it down, then so be it. But you still need to be wearing an optical device in order to restore distance vision again.
And we should probably do some myth busting here, and that is that like wearing glasses isn't going to make your eyes weaker, is it? Like just regular glasses.
Yeah, that's right. And I think let's sort of pull apart where that comes from. And you know, there are two conditions that progress regardless of whether you're wearing glasses or not. And one of them is myopia. So, you know, correcting your myopia is not the cause of the progression. The cause of the progression is that's the nature of myopia, and perhaps your visual habits during the day. And the other one is the presbyopia. It's the age-related loss of flexibility in your lens, so you can't see it as well at near as you used to, and it's a progressive condition. It's like chasing your grey hairs and your wrinkles. It keeps getting worse. The glasses, you know, your first pair of reading glasses were prescribed because you were having problems first. It didn't happen the other way around. We just can't slow down presbyopia, unfortunately. So it's just natural for your reading prescription to get stronger every couple of years.